This is the Psychcast by MD Edge, where we bring you in-depth interviews from leaders in the fields of psychiatry and psychology, masterclass lectures from key opinion leaders, and inspiration you need to keep going. I'm the voice of MD Edge Podcast's Nick Andrews. This week, Dr. Alberto J. Espay gives a masterclass lecture on Parkinson's psychosis. Dr. Espay is professor of neurology at the University of Cincinnati Health Center. He is also director of the James J. and Joan A. Gardner Family Center and research chair for Parkinson's disease and movement disorders. Dr. Espay has published some 200-plus peer-reviewed papers and more than 24 book chapters. You can read more about Dr. Espay in the show notes. And coming up later, Dr. R.K. wants to talk about something that's very misunderstood in culture. Dr. R.K. is coming up after the masterclass lecture, of course. Remember, there are robust show notes available courtesy of Dr. Jacqueline Posada. The notes include an outline of the topics discussed in the lecture, including relevant links. You can find the notes wherever notes are found in your particular listening app. It's time now to welcome Dr. Alberto J. Espay to the Psychcast.
I'm Alberto Espay, and I am a neurologist at the University of Cincinnati. My main area of interest is in movement disorders, and I treat Parkinson's patients and a variety of other neurodegenerative diseases as well. I would love to talk about the important topic of Parkinson's disease-related psychosis, particularly because there is, since 3 years ago, an FDA-approved medication called Pimavanserin, brand name Nuplazid. It is important to disclose that I have acted as a consultant for Acadia, the company that produces this particular medication, although the data that I would present would not be any other than what has been published in peer-reviewed literature. The construct of Parkinson's disease psychosis requires the diagnosis of Parkinson's disease to begin with, and that's an important element to the discussion because in reality, a Parkinsonism that appears after psychosis is really called quite differently. We refer to it as dementia with Lewy bodies. And to this date, there isn't a therapy that addresses the psychosis of dementia with Lewy bodies with approval by the FDA. So in other words, all treatments for that kind of psychotic behavior is off-label. The other aspect about the psychosis of Parkinson's that is critical to recognize is that there are many reasons why someone could develop psychosis in the context of Parkinson's disease, and as such we have to be mindful that there cannot be a single approach to this specific problem. It's perhaps best to think of extrinsic and intrinsic factors, and I like to think of extrinsic factors first. They are outside of the disease entity. They are not part of Parkinson's, but might induce the psychosis of Parkinson's disease by essentially changing the environment in which the brain lives, a brain that is under quite a bit of stress already by virtue of the degenerative aspects of Parkinson's. Those elements are typically changes in the environment related to metabolic changes, or changes because of new medications added, or changes because there is insomnia or stressors of different kinds. So these are all extrinsic to Parkinson's, but could, if identified, be used to address the psychosis, and in many cases the psychosis disappears if we have identified, say, an urinary tract infection that in fact was there and expressed not necessarily with bladder symptoms but with psychosis, or a change in the metabolism, particularly changes in liver or kidney function that could bring on this kind of abnormality. Among the extrinsic factors are the medications that we use for other conditions or medications we use for Parkinson's disease. the categories are usually either in the Parkinson's arena, dopaminergic medications, including medications that have anticholinergic effects, such as amantadine, and then outside of Parkinson's, medications used for other aspects related to the care of patients who also happen to have Parkinson's disease, particularly bladder medications. They tend to have substantial anticholinergic effects. So one of the things that we like to think and do when we see patients with Parkinson's disease psychosis is to determine the extent to which medications that they are on could be simplified, in some cases eliminated, such as bladder medications that may not be doing as much of a good effect in terms of the bladder function, but in fact may be harming patients in terms of leading them to develop psychosis. And also the possibility that we could, as we age with Parkinson's disease, reduce the number of medications used for Parkinson's, eliminate the non-levodopa formulations. Levodopa is to Parkinson's what insulin is to diabetes. That's a basic replacement strategy for the dopamine these patients aren't making enough of. But any other dopaminergic medications used for Parkinson's may have a narrowing risk-benefit ratio, meaning that there is increasingly the recognition that the side effects of these medications ultimately end up outweighing the benefits that they can induce, and at some point that window that allow that medication to be used for these patients closes, so that there is an opportunity to improve these patients by, in fact, removing those medications from these patients' regimen. If it's related to the types of medications we use, the most important category would be the anticholinergics. They typically are used for tremor in Parkinson's, trihexyphenidyl and benztropine being the two more common. The next is amantadine, for what I mentioned before. It has, in fact, anti-glutamatergic properties, and in fact, and it's important to eliminate it because patients will have often psychosis as they age with Parkinson's, and that's one way to know that that medication has run its course. Then the third category are the dopamine agonists. Eliminating or reducing them is very important. I tend to aim at eliminating them altogether. Then the MALB inhibitors, selegiline, rasagiline. And finally, I think of whether or not there may be an opportunity to reduce levodopa without the penalty of worsening these patients' function, if at all possible. If we got to a point, though, where we have excluded the extrinsic factors, there isn't an infection, there isn't a metabolic change, the medications that could have been discontinued have been discontinued, and yet the patient continues to have psychosis, then this is the opportunity to assess what options there are for the control of psychosis using currently available pharmacotherapy. At this point, then, it is critical to recognize that, as we pointed out earlier, there are several mechanisms by which psychosis could occur. There is a dopaminergic mechanism, higher dopaminergic tone, more frequent psychosis. There is a serotonergic mechanism with a higher serotonergic tone, same thing, more likely set of situations for psychosis to occur. And then there is the glutamatergic effect, and in this case, the lower the glutamatergic effect, the more the anticholinergic effect of any of what we use, and the more the opportunity for psychosis to occur. So you have these three neurotransmitters, acetylcholine, dopamine, and serotonin, that are very important for us to consider because we can manipulate either of these three and achieve effects that could be therapeutic. As I've mentioned before, manipulating dopamine by reducing the non-levodopa formulations is very effective, but there comes a time when doing so might not really be desirable, because the further down we are on reducing the dopaminergic tone, the likelier it becomes that patients take a penalty from a motor perspective and worsen motorically. Therefore, then the other options would be to alter glutamate or to alter serotonin. And we have very few options, really, in fact, none available that do so safely for glutamate, but we have one important option in terms of pimavanserin as a medication to intervene to reduce the over serotonergic tone that these patients may have. So at this point it's clear that there are a number of antipsychotics available, but only 3 are used safely or can be used safely in the treatment of Parkinson's psychosis: clozapine, quetiapine, and pimavanserin. Clozapine and pimavanserin are the 2 medications that have both well-proven efficacy as well as enough high-class evidence to show that the rate of benefits always outweigh the side effects. The only difference between them, however, is that there is a greater potential for toxicity with the clozapine, particularly with bone marrow toxicity leading to agranulocytosis, which then would imply these patients need to be monitored. That makes pimavanserin ideal in that sense, although the head-to-head comparison has never been established between clozapine and pimavanserin. Quetiapine, on the other hand, has more evidence not demonstrating efficacy for Parkinson's disease psychosis, but it is actually commonly used, and probably that is the case because it does have a favorable effect for sleep. Sleep impairment is often a feature of Parkinson's, and when patients have both sleep problems as well as hallucinations, quetiapine is used, but it doesn't have an indication for that because the evidence isn't meeting the stringent level that the FDA would have required. Therefore, we then have clozapine and quetiapine with a high-level evidence. In terms of the approval, pimavanserin is the one that has it. And what is interesting about this molecule is that it has a highly selective action against the 5-HT2A receptor. So in the pathophysiology of Parkinson's psychosis, it's clear that the excessive serotonergic tone has a disproportionate effect on the 5-HT2A receptors compared to any of the other receptors. And it so happens that pimavanserin is highly selective for this and virtually for no other type of receptors, which is what was demonstrated in the pivotal study that showed that in addition to accomplishing the endpoint of changing the endpoint, the SAPS-PD, which is designed as a way of measuring the specific behaviors of Parkinson's disease psychosis, namely hallucinations and delusions. It also demonstrated that there were very few, if any, meaningful off-target effects, further confirming that the selectivity for 5-HT2A in fact is demonstrated in clinical practice, with side effects that are compared to placebo relatively low and restricted to edema, peripheral edema, and confusion, but virtually no major differences otherwise when compared to placebo. It is important to note that there are a number of patients, still in the minority, but important for us to in the future determine, who might worsen with this medication. We don't know who they are, but it is clear that this is an issue that was in fact identified initially in the clinical trials, and hallucinations is rightly listed as a potential side effect, which seems counterintuitive for us, but we know that in fact it can happen in a minority of patients, and in the future hopefully pharmacogenomic strategies will allow us to determine who they may be so that we would not expose them to something that will in fact make them worse than what they were prior to treatment. So at this point it's important then to realize that we have the first FDA approved medication for psychosis in Parkinson's disease. The only caveat for this medication to consider in patients is that it may extend the QT interval. So if you have individuals with other therapies that may have such effect, you could conceive the scenario where the QT interval will be extended beyond a time or beyond a time lag that will not be safe for patients. That is important to keep in mind for patients with heart disease, substantial heart disease, and in them it may be important to do an EKG to ensure that a baseline is established so that there may be some monitoring of that particular risk. Finally, when the data of the pivotal study has been analyzed in terms of what may have driven the larger increases in the antipsychotic efficacy, it has been recently shown that it may be greater among those who have, in fact, cognitive impairment and dementia, although the pivotal study was trying to exclude patients with dementia. Some patients, a few of them did become part of the study, and sub-analyses have shown that those individuals may in fact have the greater magnitude of improvement, and congruent with the concept that serotonin and cholinergic pathways are affected. If you have patients on anti-dementia medications, which are essentially cholinergic medications, you can conceive of larger efficacy, and that has been shown also in published post-hoc analysis of the pivotal study. So in conclusion, we have essentially a very good set of therapies, but one that has recently received FDA approval. Psychosis is an important source of disability for patients with Parkinson's disease, and it is critical for us to recognize it earlier because there is a treatment, and because perhaps by doing so we may attenuate the possibility that these patients lose their independence and may have to be institutionalized with quite a bit of care. It has been shown, and I didn't mention it earlier, that psychosis is one of the most common reasons why patients with Parkinson's get into a hospital, and in fact why patients may ultimately be placed in a nursing home. So I hope that this has been helpful. And certainly the field is evolving, and we can envision a time when other medications may be developed for this important source of disability in Parkinson's disease.
The Psychcast by MD Edge will be right back. It's time now for Dr. Renee Kohanski.
I was asked to comment on the homeless in America in a recent radio interview, and this interview has stayed with me for many reasons. It's a complex issue and crosses so many different areas a doctoral thesis wouldn't do it justice, let alone a radio interview, or even this Dr. RK segment. And of course, in a radio interview, thoughts come up which you'd like to develop or expand, and at best you have 2 minutes to do it. So rather than even try, I'm going to put it to this audience and ask you to think about it. The common uniting feature of homelessness is poverty, but poverty alone doesn't do it. It's poverty plus something. Just being poor doesn't lead to being homeless. Living life with absolutely zero cushion leaves no room for error. It can be poverty plus recent job loss, or poverty plus divorce or separation, so now you have the additional loss of income when you were already on the edge. Poverty plus insufficient mental health treatment, or poverty plus substance use. So you can think of a million different situations. When you are just barely making it, and I mean barely, it takes very little to push that envelope. My colleagues who work in community mental health are intimately familiar with this. Teachers who teach in any system are familiar with the precarious situation. If you are dependent on a system with limited resources, and then the system is suddenly overloaded by needs that exceed the system, whether it's because the system is suddenly overburdened, the system collapses and you are left with nothing. So the next issue that came up in the radio program was the role of law enforcement. Looking at this from a purely psychiatric perspective, many of us have seen the criminalization of the mentally ill. I'm talking about a small percentage of the homeless, individuals who are seriously mentally ill, often non-compliant with treatment. They are then arrested for vagrancy or some other nonviolent crime. While they didn't need to be in jail, it was a roundabout path to treatment. And law enforcement was becoming quite comprehensive in many districts, with social work having an extensive and long-reaching arm with resources such as alternative to incarceration involving treatment. Now, obviously, a better solution would have been to bypass law enforcement altogether, and I actually believe we were headed in that direction. Unfortunately, with some of the changes, such as removing law enforcement completely, they have, for all intents and purposes, eliminated any hope of treatment for some of the most needing of treatment. Certainly, it seems to me, with all the millions of dollars we spend on endless inquiries, we might just inquire about this and find some humanity and dignity for our fellow human beings. And remember, there but for the grace of God go I. I'm Dr. Renee Kohanski for the MD Edge Psychcast.
And that concludes this edition of the Psychcast by MD Edge. I'm the voice of MD Edge Podcasts, Nick Andrews. The Psychcast is produced by psychiatry editors Gina Henderson and Jeff Bauer. All MD Edge podcasts are produced by executive editor Kathy Skarbeck and Mary Ellen Schneider. You can find all MD Edge podcasts wherever podcasts are found.